thank you to be part of these outstanding events. And of course, congratulations for your efforts to have so much friends, and say hello, everybody. My topic is to talk about anterior cranial base fracture and why just the anterior cranial base fracture. Because from the epidemiological point of view, the anterior fossa is the main part of interest in the skull-based trauma. And if you think about the epidemiology of the central skull base, we can understand how these take the majority of the skull-based trauma. If we try to make a classification of this kind of fracture, until now is difficult to find a univocal classification, and so the consideration that the AO Neuro did some times ago is still valid. So the AO group developed this kind of classification. Is very complex with increasing level of complexity and details, but is much more useful to compare results among surgeons and institutions. From a practical point of view, all the classifications are all bone-oriented, and you can find a lot of these classification. One of the last classification is by Archer, and it's always the same approach, and this is the first take-home message. I mean, the approach of a classification is just to take in consideration the extension of the fracture. So this classification, for example, starts from the class 1 with the cranial and endocranial surface with anterior or lateral extension. The passage of the second grade is the involvement of the ethmoid bone, even frontal or lateral. And the final step is when the fracture involve all the bone of the cranial anterior cranial fossa. So this is the concept that we have no only one classification, but this is the message. When you try to classify your patient, you have to understand these three fundamental passages. The main important classification from the practical point of view is that you have to divide the trauma in the upper third or the mid-face area. And why? Because if we have a trauma of the upper third, we know that we have to expect the possibility to developing of brain contusion. And if we have a fracture of the mid-face, we can expect the CSF leak occurrence, and we can expect the occurrence of CSF leak up to 20%, about 20%, even after the initial repair. And is another practical point of view that the upper third can be approached mainly by microscopic technique or endoscopic, less for endoscopic technique, while for the mid-face, the main approach will be the endoscopic approach. For planning reconstruction, I will not talk deeply about the reconstruction technique because I know that follow me, there will be Domenico Solari, is a great professor with a great experience of the reconstruction of skull base, so he will illustrate for sure all the technique. For the trauma, just a few suggestions to prefer autologous bone to repair the inner tables when you have exposition of the bone is better to repair with the bone. For the face, titanium mesh could be preferred for small defect. Of course, customized processes for larger defects. And about the sealing, it could be better to prefer a vascularized flap as much as possible. So periosteal for Calvarian reconstruction and anterior skull base reconstruction, and nasosectal through the endoscopic technique. Vascularized free flap only special case thinking about, for example, rotation of the muscle. And I cannot talk more on this because here we have Professor Atudol that illustrates so beautiful papers about the use of the preserving of the muscle, temporal muscle in these cases. So about the timing is another. This presentation is about the planning. What I have to take in consideration when I plan the treatment of a skull-base fracture. Most frequently, the timing is a scheduling planning because it's better to for aesthetic results. And if we wait, the problem is that we can have a great difficulty in anatomical reduction of bone fragments. So this is the reason when we work with maxillofacial surgeons, maybe they have a little bit afraid that this delay can provide some difficulty in anatomical reduction. Anyway, if we have intracranial hypertension, cerebral contusion, CSF fistula, or encephalocele, we have to plan our surgery. So, for example, in this case, we have this young male with a severe traumatic brain injury and a complex facial fracture. For sure, the first approach is the emergency neurosurgery with the bifrontal decompression due to the treatment of the brain contusion and the intracranial hypertension. And after, we have to schedule the maxillofacial surgery when we assist at enough resolution of acute brain edema. And so we can provide a reconstruction of ethmoid, frontal sinus, and left orbit, but we can still maintain the decompressive approach because we have to wait for the reconstruction. And after the reconstruction will be after 4 months with autologous bone cranioplasty. Or the other case of this male, 35 years old, Glasgow Coma Scale 13 on scene and recovery 1 point at emergency room with a complex fracture of ethmoid orbital and right pterium, bilateral zygomatic and orbital ethmoid frontal on the left side with the involvement of lamina papyracea and so on. But we have also a brain contusion, initial incipient brain contusion. So it's better to wait and to wait if the contusion can progress or not. Taking in consideration the normal neurological status, we have to remember that contusion can have a biphasic progression. The first risk within 2 days, and the second risk is about after 5 days. So they can progress in a volume, and so it's better to wait enough time to plan a reconstruction. So 1 month after the trauma, we perform a combined surgery with neurosurgeon and taking consideration the relevant aspect of the frontal sinus cranialization each time you have this kind of trauma exposition, and after the reconstruction by the maxillofacial surgeon. And so it's clear that we have to plan this kind of patient, this kind of surgery. If is it possible to plan this? Of course, if we have a depressed skull fracture or hematoma, we will know the classical indication of TBI. We cannot plan so much, but when we went in early surgery, we have also taken consideration the frontal sinus cranialization when the fracture take part of that site. The other aspect to take in consideration for timing is the presence of rhinorrhea. So if we can expect that if we have no rhinorrhea, we can wait more, but if we have a persistent pneumocephalus, even in absence of rhinorrhea, this is an indication to plan a surgery. And about the management, the strategy with CSF leak, when we have 1 centimeter, less 1 centimeter diameters, we can wait, we can plan waiting for the spontaneous resolution. Spontaneous resolution that is very difficult if the defect is much more than 1 centimeter, especially if we assist a traumatic pneumocephalus, comminution of the fracture, and especially a central location. Once again, the site is of the fracture is one kind of classification. About operative approach, you can choose the classification that you want, but it's important that you take in consideration the involvement of the cellular region or the involvement of extension behind the cellular region for the approach. The recurrent CSF fistulas, of course, after the approach, can benefit from the endoscopic approach. So this is another flow chart that you can find in literature, and it's quite almost the same indication in several papers that you can find in literature. What you have to pay attention is about the displacement of bone, more or less than 1 centimeter, and the location, once again, midline, and involvement of cribriform plate and the presence of encephalocele. So conservative management is where we have no these aspects, and but the surgery can be considered if we have a persistent rhinorrhea, of course. And another important aspect is the presence of encephalocele. The encephalocele is a brain dislocation through the ethmoidal region, and we can have rhinoricorrhea and meningitis, or the brain dislocation is through the orbit. And the clinical signs could be for the orbit encephalocele, could be orbital ecchymosis, ophthalmos, alichoria, diplopia. But what is very important to note and to research is the radiological signs, the blowout of the orbital roof, and the brain herniation through this defect at MRI. Once again, another kind of the classification. You can imagine each time that we manage a fracture, we manage trauma, we have a lot of classification, but this is just to remind you that when we have a orbital roof fracture, we absolutely keep attention about if the fracture is blow-in, so the roof is displaced inferiorly, or blowout. When the roof is displaced superiorly, we have to suspect the presence of encephalocele or to careful follow up the patient. So we have to operate the orbital encephalocele because we can have a mass effect in the orbital, and so the brain parenchyma is not functional, and so this is the blowout fracture, and you see in MRI how the encephalocele could be orbital or ethmoidal or both. So the orbital encephalocele is mainly approached by craniotomy, and ethmoidal encephalocele could be approached even from craniotomy and by endoscopic approach, like is illustrated in this nice paper. This is an example for the primary bifrontal decompressive craniectomy. Has been the first approach because we have to treat the emergency, and we perform a cranialization of frontal sinus with periosteal flap. Then, after 1 month, during the follow-up, we recognize ethmoidal encephalocele that has been treated by neuroendoscopic coagulation and encephalocele, and middle turbinate mucoperiosteal free flap for dural repair. Or this other case, once again, we have a bifrontal contusion, so the emergency required by primary bifrontal decompressive craniectomy, always with cranialization. I repeat all this time, especially for young neurosurgeon, the importance of the cranialization of the frontal sinus in this kind of fracture, in this kind of TBI. During the follow-up, we still, after 3 months, we assist a recurrent hyperthermia without rhinorrhea. So we revise the patient, we check it, a CT scan, and we note how wide is the ethmoidal involvement. And even if we do not assist the rhinorrhea, because more often the brain occlude the possibility to have a rhinorrhea. So the MRI disclosed at ethmoidal encephalocele, and so the patient has been operated with the endoscopic approach with neurosurgeon and ENT. So the consideration about this is that for the treatment, we need adequate exposure of the bone defect, and the resection of the meningocele or encephalocele is quite easy. It's not functional brain. For the small defect, we can use free flap. For large defect, maybe is much more better fascia lata or abdominal. Fascia lata, autologous fascia lata, or recently we use also a banked fascia lata, so we avoid the donor site complication. So at the take-home message, so that we have two-plane management. Two-plane management, we take consideration the bone extension of the fracture, pay attention about the midline involvement or lateral involvement, and midline, of course, needs more attention. Sinus extension, anterior, posterior, both the walls, so the needs to perform canalization, endocranic extension, so dura repair, brain contusion. This is all the main aspect to take in consideration to plane management. The surgical treatment could be in emergency, especially for the brain complication or the trauma. The scheduled treatment is the main part of the planning, and when you schedule the treatment, pay attention to the presence of encephalocele. So it's clear that it's complex cases. It's better to have a group with neurosurgeon, neuroradiologist, maxillofacial surgeon, ENT surgeon, and because good classification still now it is difficult to obtain, it's better to adopt a multidisciplinary local protocol, and where all together can decide which kind of classification and which kind of main aspect should be analyzed for the flowchart of the planning surgery. Thank you.
Thank you, Professor Laccarino, for this excellent presentation.